that set off some kind of a light bulb in me, where he basically said, and he said he had like 12 minutes to speak, and he wasn't even sure he was going to go to this conference because it was only 12 minutes and he wasn't sure, but that 12 minutes changed my life. And what he said was, listen, you doctors, you go out there, how many hours are there in a typical church service? How many Sundays are there in a year? And then count up those number of hours. And what was it, like 16,000 hours? And he said, and you think that after 16,000 hours of a person's life, they're going to come into your hospital and they're going to hear some doctor, a white doctor usually, say to them, there's no hope here. We've got to plan for the end of life because there's no hope here. And you think all those 16,000 hours of talking about hope and talking about faith is going to change that person's approach to the world? And it was just a light bulb for me. And I realized that I had been approaching this all wrong. And so I thank you. And again, Betty, there you are, Betty. But Betty, Betty has been a tremendous mentor to me. I'd say my most important mentor all of these years of practicing and trying to understand what's important when you really think about taking care of people who are sick. And this idea that Betty always says was, there's always a story. And I realize, and I've learned this over the years, that I have my own biases about people. And I come into the room and a lot of times they're just spot off. And I think race is an area where we have to be extremely careful. There's many types of biases you can have that will impact the way you take care of a patient. But race is one that has particularly caused tremendous damage in our country, and I think is one that we have to pay particular attention to. So.
Thank you. So let's dig into that a little bit, right? When you say that biases around race have led to disparity in healthcare systems, and particularly you spoke of end of life. What does that look like when we say this? You know, we've used this term already a couple of times in the last 10 minutes of racial disparity in healthcare. What does that look like? How's that playing out in hospitals, in doctor's visits, in your experience, you know, as a pastor, Corey, and as a doctor, Jessica?
Go, Corey.
Well, I think for me, you know, as it relates, I think for me, as it relates to disparities, can you hear me okay?
Yeah.
I just want to make sure you can hear me okay.
Yes.
So as it relates to me, as it relates to disparities, one thing that we need to make sure that we understand is the difference between health disparities and health inequities. There's a difference between the two. Health disparities deal with the actual differences as it relates to race and ethnicity or socioeconomic status, gender, sexual orientation, disabilities. All those things go into when how a person is treated is based upon those things, then those create disparities. But health inequities are actually systematic and unjust distribution of social, economic, and environmental conditions needed for health. So when you get into the health inequities that are caused by health disparities, you get into the quality of education, you get into housing and transportation, lack of food or grocery stores in certain areas, unequal employment opportunities, and all those things begin to play out as health inequities that are representative of the health disparities that we see. And so when you talk about doctor's visits, where are those doctor offices located? Are they located in a community that's where those offices are of quality, they're accessible, they're easy to get to, or if they are not, can doctors provide the ability for people to have transportation to those particular facilities? So those things get into what we know as healthcare disparities or health inequities, and so we see it play out in society when people are separated from access to healthcare each and every day.
And I would, I see it. I mean, the data that comes out about the differences between sort of African American access, just forget for the health outcomes, but just the access. I mean, the stories of people not having access to hospitals, and this is something we Jewish people can also relate to, not actually being able to come into a white hospital. And I've heard stories from Betty that have really chilled me to the bones in her life. And then once you get into the hospital, once you actually are in the face and the presence of the healthcare system being treated, how is that differentially being impacted? And we talked a little bit about implicit bias. Most of the healthcare workforce is white. And we are taking care of African American patients who are coming into this history of lack of access, of unethical experimentation, which, as we all know, has happened, of a healthcare system that hasn't responsibly or ethically dealt with groups of people. And we are sort of all in there trying to have a relationship, because healthcare is about a relationship. And if the two pieces of the relationship aren't connecting on a very basic human level, then that relationship is flawed. That relationship is going to potentially go off in a direction that is going to cause more suffering than is already present from the disease. And so I think that we just have a system where a lot of people aren't getting access. They're not trusting the system for many, many reasons that are completely understandable based on the history of our healthcare system and of our current structural racism in this country. And then when they get to the system, it's often very late in the course of disease, and they're dealing with people with whom it's very hard to have a therapeutic relationship. There's just a whole lot that's in that room that is not productive in terms of really connecting and figuring out what is best for this person right now, both medically, socially, spiritually, and that is what is happening in hospitals and primary care, not emergency rooms around this country, and particularly so now with COVID. I mean, COVID is an example. 30% of the fatalities are African Americans, constitute 30%, and they constitute 13% of the population. So there is, clearly something happening here, systemic, that really needs to be addressed. And there was an article that I read that said, COVID is unmasking something that has been a part. It's really just an exaggeration and unmasking of something that's always here. And I think that's really important for us to understand.
Yeah, so there's a question actually that I think connects to something you just
So I
talked
was actually kicked out there for a moment.
Oh.
Well, welcome back. It wasn't personal, I promise.
Is he back? I don't see Corey.
Corey? There you are.
Is he back?
I see you now. Can
Rabbi Shuli, the sound is choppy on my end. I don't know if anybody else is experiencing that.
No, we're hearing you fine. Corey?
We can't see him.
Can't see him, can't hear him.
Not see him.
Okay, well, until he comes back, do you want me to, well, you had another question, but I can.
I had a question for you, and I'll just say, Corey, if you can hear us, feel free to call in by the audio, that might make it a little bit easier. So feel free to do that if that's better for you. And so Jessica, I wanted to ask a question that someone put to me in the chat, which speaks to what you just mentioned about implicit bias. And you said this at the beginning, that you have noticed there were times where you've walked into hospital rooms with all kinds of assumptions that were totally wrong. Mm-hmm. So can you give us an example of that? And can you talk a little bit about cultural competency, and how have you developed cultural competency, and what would you want to see for other doctors to develop cultural competency?
Well, first of all, I don't actually believe we can actually develop competency in anyone else's culture. I mean, I think what we can do, the best that we can achieve, is what they're starting in medical schools to call cultural humility, which is really to understand that you don't know. Not only do you not know another culture, you don't know another person. You just cannot know. all of the things that brought them to that place at that moment. You can walk into a room and you can wonder, why is this patient here alone and why is his daughter not here? She says she cares but she's not here. I haven't seen her for 3 days. And that is something that I have felt at times. And again, Betty always says, you don't know the story. And then Betty will frequently come back to us and she will have gotten a story that is eye-opening. This person they don't have money to get on the bus. There is always a story. There's almost always something that you didn't even think about that changes your whole way of thinking about that patient and makes you view them like that in a different light. And both in positive ways and in negative ways. If you see somebody who comes in, we had a patient, Betty will remember, who had a gunshot wound to the abdomen or to the spine. I mean, and he was an African-American man, and I'm not proud of this. I thought this was some gang-related thing. Well, thanks to Betty, and I may have found this out eventually because I'm getting better at starting to think about the fact that there's a story. Betty said, actually, did you know that this guy was a postal worker and he was delivering the mail? And there was a whole story behind this that completely shifted the lens of how I looked at this patient. I'm not proud to tell you these stories, but it's just the truth. Here's another example. If we have patients who come in, and I write a lot about this in my book, there's the patients in bed 5, they believe in miracles. There's a lot of times doctors will sign out a patient to another doctor, say, oh yeah, the patient in bed 5, they believe in miracles. That is code word for don't even talk to them about goals of care. All they're going to want is everything. And you know what? I used to feel that way. And you know what? I was completely wrong. And miracles, the word miracles might mean something to me. And it might mean, and it almost always means something completely different to the person who's saying it. And the only way for me to know that is to really ask them, what do you mean? What are you talking about? What is a miracle to you? And I have to tell you, much more often than not, it's not what I thought it meant to them. And so it's really all about creating a relationship, asking questions, respecting a person as a person who comes to you for help, but who has a life and a set of values that are important to them, and really trying to understand it as much as you can, trying to get to that story that Betty always talks about.
So tell us a little bit about, how much time does a doctor have to ask those stories, right? We hear so much about the healthcare system, doctors are rushed. There is a time even to, just sit and hear a patient's questions. And particularly now, so many people coming in with COVID or with symptoms and all the anxieties that doctors have, I imagine, of being in a room with a patient. How could you imagine things looking a little different to create more of that time to hear the stories?
Well, good question. Because we not only see that from the outside when we watch things like Grey's Anatomy and ER, we think doctors are so busy, they have more important things to do than actually sit down and have a relationship with a patient. And actually, that's not true. I will tell you, as an ICU doctor who works in a very busy ICU, there's always time. There's always time to have a conversation with somebody. And you don't have to have it all in one sitting, but you can always have time to have a relationship with somebody, to say, I'm going to come back when I have a moment, to show people that.
Sorry, I had a little issue with the mute there. Go ahead.
The other thing I will say, specifically as relates to COVID, this is important. I'm actually working right now as one of the volunteering with a whole bunch of other healthcare practitioners in New York City. I'm actually working at Woodhull in one of the public hospitals and coming in virtually and doing a whole bunch of consultation. So I'm seeing kind of up close and personal what's happening in New York City during COVID and taking care of some of these patients. And, there is some truth right now to the fact that these doctors are very overwhelmed. And they put out a call to help to our palliative care community, and many of us answered it. And it has been, I'm so appreciative that they called, and I'm so happy to be able to be in there and help. And even with that, there are still ways that we can get those moments of humanity. Can't tell you how many times I've had some earnest young resident donning all of this PPE and taking the phone with me on it, pulling in the family member who hasn't seen this person for 3 weeks, and going into the intensive care unit with the person on the ventilator and having a conversation with that family for the first time in weeks, because things have been busy, but these residents are there and you can see how they feel being a part of that interaction. And they don't necessarily know how to do it themselves. So a lot of this isn't about time limitations as much as it is about fear of communication. Fear of COVID, yes. I mean, you don't want to be in a room for a huge amount of time. It's not like these are long interventions, but even small interventions, bringing that humanity, bringing the family together, having a visitation experience where people can connect again, those enhance the experience of connection and of true therapeutic intervention. And these residents, I can see they're busy, they're stressed, but they feel something really powerful about having been able to do and be a part of that interaction. So my answer to you is, that's a long-winded answer, is there's always time. There's a lot of fear. Forget just COVID. There's a lot of fear about communication. There's fear of emotions. And we have to teach our healthcare workforce, we have to teach our residents, our medical students, and each other that being afraid of emotion is not an excuse to avoid a conversation. It's not an excuse to avoid connecting with a patient and family. And that's something that we learn a lot in the palliative care movement, but we have to spread this around to the rest of the medical community as well.
Great, thank you. We'll come back to that in a minute, but I just want to note, it looks like Pastor Corey's having some trouble getting on, and I'm going to try to connect with him by text and get him back. But I'm wondering in the meantime if it would be okay with you, Jessica, and if okay with you, Betty, not to put you on the spot, but if we could bring you into the conversation.
Shuli,
yes.
I did get on.
Maybe we could bring you into the conversation, Betty, if you want to share a little bit on this perspective, your perspective on this question from what you've seen and maybe even what you've experienced or people you know from African-American community have experienced.
Hi, yes.
And thank you for jumping in.
Yes, thank you. I was just listening, and the question about how do you doctors get enough time? Well, I don't think they use the spiritual care department enough because we have time. And as we go in and get the stories and then write up our notes, all the doctors have access to that. And I found at hospital that it's just a matter of learning, of understanding that there is another partner in this healthcare that they can get access to. So I've had them come to me and say, Betty, could you join us in this meeting? Or Betty, we read your note and could you tell us more about what's going on with the patient? So it's using everybody and understanding that spirituality is not about religion. It can be, but it's not about religion. It's about the whole person. It's about getting an understanding of who this person is, what their hopes and dreams and what lifts their spirits and what struggles and troubles they've had sometimes way back that affected their life now affects their decisions about health. And whether or not they're complying with the doctors has to do with sometimes about how they were treated as a child. And when I find that out and I share it, it helps the doctors to understand the person in a more humane way. That make sense?
Thank you. Thank you. I saw Corey is back. Corey, are you with us? I see you. Can you hear us now? You want to unmute yourself? We see you. I hope you hear us. Welcome back, Corey.
Yeah, I know. I don't know what's going on. I know that for me, in my area, Zoom was down early this morning. and I don't know exactly what's happening now, but I may do one more thing here. I think I'm going to switch devices, if you don't mind, and then come right back in.
Absolutely. Absolutely. So we'll give you a minute to do that.
Okay.
And we'll see you
Yeah.
in a moment. Okay. Thanks. Jessica, did you want to add something right now?
Well, I just wanted to, really point out about Betty, again, we work very, very closely. And I'm curious, I mean, Betty has been in this palliative care world, which is, it's a different model for anything that we know in medicine. It's the first subspecialty. It's a new subspecialty, really started in 2008, where we bring together experts who are from a variety of different subspecialties. We've got obviously chaplaincy expertise, we've got medical expertise, we have a social worker, we have all these different players. This model makes it so that all these different players are looking at the patient from just a variety of different angles, really, which sharpens our ability to understand that person in their totality. And Betty once said to me something which I think is so interesting. She said it a few times, that she feels like being in the palliative care world is the first time. Well, Betty, what was it? You said it's the first time you've ever felt blank.
Holistically included into the medical care, because I was a hospice chaplain for 16 years before I became a palliative care chaplain. And even in the hospice, you don't really get to walk with the doctors or be aware of all the medical nuances going on with the patient. Where in palliative care, the chaplain is an integral part of the care. And you feel like you really are caring for the whole person, where in most of our medical models, it's kind of fragmented. And I believe that all teams should have spiritual care and associated with the team, so that the chaplain can go in to see the patient. Even if they don't go in with the team, they still have the medical information, which is part of the person, affects the person's whole being, their spirituality, what's lifting them, what has them down. I have volunteer chaplains, and they visit or call a patient until they know what's going on with them medically. I inform them what's going on medically, because that informs how you care for them spiritually.
Absolutely. And I would also like to point out something which I think is a really important infrastructural, systematic, cultural problem in healthcare, which I think leads to all the things, the disparities, issues, and inequities that we've been talking about. But it has to do with hierarchy. It has to do with the way typical medical teams are organized, where there's a doctor at the top and everyone else, and that doctor owns the patient and is responsible for everything and every decision and doesn't really take a whole lot of input from anyone else. And that, I will tell you, I mean, that is a terrible system, because it's terrible for the patient, obviously, because the patient isn't getting this multiple sort of view of them as a human being. And so the decisions that are getting made really aren't necessarily tailored to what their preferences and values are. It's terrible for the other members of the team, because let me tell you that a nurse in the ICU who has to go carry out an order that feels completely unethical sometimes, or just completely unpatient-centered, and they don't have a choice. They've been handed down this order. They have no say, no input. That is a recipe for moral distress. And I can tell you also, for the doctor, who's that person at the top of this hierarchy making the decisions with all this power, it's not a good system either, because that does not bring out your humanity, because your whole goal at that point is to show how smart you are, to show how in control of the situation you are, and to never let them see you sweat. And this is a real problem on all fronts. And I think that's the thing about working with Betty. For me, to see Betty as my colleague who has so much to offer, and frankly, so often I feel has more to offer than I do, and so much to teach me, that has been, and I will not say that I came into that relationship willingly necessarily. I kind of wanted to be, Betty kind of massaged me into it, and I thank you for it. But that's made me 50 times the doctor that I ever was before. And if we could figure out how to take that model of collaboration, mutual respect, smashing the hierarchy, and really thinking about the patient ultimately, and bring that not only through the palliative care movement, but to the rest of medicine, we would, I think, do so much, as Betty pointed out, towards bringing a more humane system to our healthcare. Now, by the way, I think part of that also not only includes having a diverse professional team, but also diverse in terms of race and in terms of other properties. We have got to diversify our healthcare workforce. And Shuli, you asked me, what are some things we could do to make it better? We've got to have more African American doctors. We've got to have more African American nurses. We have got to have more chaplains on our teams. We've got to just really make this a more hospitable environment, not only for the patients, but for all of us.
Great. So I want to come back to that question of change and how do we change the system. And I think that's a trope that I'm hearing a lot of, and I think a lot of us are hearing and seeing a lot of, not just about race and healthcare, but all kinds of things that are being, I wouldn't even say coming to light or being exposed. There are problems in our society that we've known about for so long, but they're really getting a spotlight because of the COVID crisis, which in some ways hopefully opens up an opportunity to talk about really changing systems and changing structures. And so I want to dig in for a moment on the COVID crisis. And Corey, I know you're back with us. So I want to come back to something that you said earlier about the difference between racial inequity and racial disparity, and how the inequities that are much larger than what presents in the healthcare system, but have to do with economics, with education, with all kinds of other things, lead to disparity in the healthcare system. And I wonder if you can talk a little bit about how are you seeing that play out right now in the current COVID crisis?
Oh, Corey, I feel so bad.
Well, if I can jump in for a moment.
Yes, there you are. Terrific.
Yay.
Oh no, I don't know what's. Yeah, I don't know what's going on. I know that once again, my Zoom feed in my area was down earlier this morning, and we had to switch how we did services and everything. So, because I was using Zoom as a part of that, and so anyway, it's not your fault at all. But as it relates to what you just talked about, for me, I am seeing really this being played out here in Detroit. And I know you in New York and even all over this country, any inner city or any large city, we're seeing this being played out in a devastating manner. It has been said that in America, if America catches a cold, the Black community catches pneumonia. And, when you think about a statement like that, you think about where the disparities lie within the communities and across the spectrum in healthcare altogether. And so there's so many factors that lead to where we are with the amount of deaths. And I don't know if Jessica, you brought this up about the large percentages of African Americans dying from COVID-19, but it has everything to do with the things that have been going on in healthcare for a number of years that have really never been addressed. And so COVID-19 is really just revealing a lot of the ills and a lot of the disparities and the health inequities that have been present for so many years, for decades, and even, dare I say, hundreds of years as it relates to healthcare in and of itself. And so when you look at a community that already is, and I just want to read a few statistics so that we can understand the breadth of which we're actually trying to address this issue. African Americans are 44% more likely to die from a stroke, and 40% more likely to die from breast cancer. 2 times as likely to die from prostate cancer, 25% more likely to die from heart disease, and 23% more likely to be obese. And so when we think about these factors that really COVID-19.
Oops.
Well, looks like you froze there for a second.
Well,
We'll come back.
and just to add to that, those statistics, by the way, do you know that African Americans are half as likely to get treated for pain for routine types of illnesses like appendicitis? Children, African American children are, I can't remember the exact statistic, but it's about half as likely to get appropriate pain medication for an appendicitis when they show up in the hospital. And for long bone, they did a study on long bone fractures, which are extremely painful for patients in emergency rooms. Again, significantly less likely to get pain medications for those. And again, those types of different treatments, treating groups different ways, that has really everything to do with bias. You know that there was a study that was done recently with a bunch of medical students at a Southeastern medical school, which I shall not name, which basically showed an alarming number of them believing differences between Black and white bodies, physiologic differences, that African Americans have fewer pain receptors in their extremities. That African Americans' bones are thicker, so they're less likely to break. I mean, things that are just based in no way on fact, and that the treatment decisions that would come out of that, the hypothetical treatment decisions, would be very different. They would be less likely to give them pain medications. They would be less likely to take them seriously. These are built-in biases that are causing profound suffering. And so, I mean, we have to start to confront these types of realities and this data. I mean, this is data. This is real stuff that happens. It's completely unacceptable and must be turned around. And sorry, is Corey back yet? Or
Yeah, Corey is back.
oh, yay.
Okay.
Corey, let me. You should be able to unmute yourself, but if you can't, I'm going to find you and unmute you. But yeah, Corey is back.
Good. Corey, you there? Poor guy. Sorry, Corey.
Sorry, Corey, and sorry, everyone. Thanks for bearing with the technical difficulties right now. There you are, Corey.
Okay.
You should be
All right.
muted now.
All right.
Welcome
Yeah.
back.
So what I did is I had my son go and just reset my whole system.
Yay, son.
I think we're good now. I think we're good. So anyway, and just trying to pick up where I left off, and I don't even know where I left off, but the reality is that so many things go into what we call healthcare disparities and healthcare inequities, and it deals with the basic things about where people live, where they shop. Here in Detroit, and I want to let you know that when we look at food centers where you can get decent food, grocery stores, there's not one major grocery store chain within the city limits of Detroit. There are smaller, pop-up type of grocery stores. A lot of people do their shopping at these, CVS places or Rite Aid. People are actually buying groceries from these places, which leads to, poor food, poor eating habits, which leads to that 23% obesity rate, death rate that I talked about as it relates to African Americans and people who are living in the inner city, so to speak. And so it just all feeds this beast of healthcare disparities. And on top of that, the social structure and the structure of the healthcare system, which Jessica talked about, has everything to do with, how people of color may be looked at. And so, many people of color are already behind the 8 ball, so to speak, when it comes down to health. And so, when getting help is needed, we're not always looked at in the same way. And it's unfortunate here in America that things are the way that they are, but we are not looked at in the same way. And so Jessica and I are desperately trying to, along with you, all of you on this call today, you wouldn't be here if you didn't feel the same way. we're all trying to make a difference and make sure that we're doing our part to keep these things from continuing to happen each and every day. But when we look at Detroit, and I want to just, highlight Detroit for a moment, the highest death rate in the nation is right here due to COVID-19, which has revealed that the highest healthcare disparities or inequities are present right here, because we know that this disease feeds off of those underlying conditions that I even brought up earlier when we deal with the poor health that people have to begin with. So can we do things to change that? Yes. We can help people. People, can exercise more. They can do certain things more. But it comes down to access. It comes down to parks in the community. I don't know how many, people have decent parks to walk in, to even get exercise in their community, and feeling safe and things of that nature. All these things are factors that lead to a poor health condition for all individuals who live in those communities.
Yeah. So we're raising up and talking about a lot of things that can be acted on from the doctor side of things, perhaps in medical education, training, some of the other larger systemic issues that need policy interventions. There's a question in the chat about assuming one is hospitalized in a place that is less sophisticated in its holistic care, what could a patient or advocate do to prompt the kind of conversations you are describing? So, maybe this is a question for you, Pastor Corey. How do you advise people, whether it's members of your congregation or people who you're pastoring to in the hospital setting, how do you advise them or their family members to advocate, while we're sort of waiting and trying and hoping for that larger systemic change to happen? How do you address it from the patient perspective?
Two things: God and Google. Those are two things that I think are monumental. Lots of prayer. Yeah, and we all are. In our faith communities, we definitely, go towards prayer, but also to find out as much as you can about not only what health condition you're trying to find out, whether or not you are, dealing with, but also to understand the structure of healthcare systems. I think that many people go in not asking enough questions about, what really is the doctor thinking? What is the nurse thinking? Here's a great example. There are older people in the African-American community who have been conditioned, and Betty knows about this. They've been conditioned to not question the doctors. They've been conditioned to not question those who are in medical authority leadership. And that is an issue because if you don't bring any questions to the table, if you don't push for certain answers from the medical team, then you're left wondering, what can be different? What can change? The change is only going to take place when people begin to take seriously the fact that they need to question the doctors, and not question them in a negative way, but to ask questions of them so that they can be more knowledgeable about their own care. I think the day has left us, and the day is over where we just sit back and we accept the care that's being given to us without asking about the medication or the side effects. How does it impact us? How long am I going to be on this? Long term, short term? What does that mean? How does it impact my ability to work or to live in a meaningful way? And these are things that people have not often asked. And so when you don't have, there's an old adage that says the squeaky wheel gets the oil. If you don't, squeak enough, if you don't ask enough questions, then things won't change. So I try to help my congregation to be more knowledgeable health-wise of what's going on, because I think health is a great part of our spiritual walk and spirituality as a whole.
Yeah. Can I mention? Yeah. Can I mention? I know that Reverend Cynthia Perilliat is on the call. I see her phone there, and I don't know if she's still actively listening, but she is the leader of and founder of an amazing program here in Oakland, California, called the Alameda County Care Alliance. And what I think they're doing, which I think is brilliant, is trying to create sort of empowerment among the African American faith leaders community, in the African American faith communities in general. But one of the things that she and I are working on together, which is to take our movie Extremis and to create a discussion guide that is specifically geared towards educating and empowering African American faith leaders about end of life realities. What happens in the hospital? Understanding stuff that lay people don't typically understand. I mean, Corey understands it, and Betty, because they're in the hospital. But if you're a chaplain, unless you're a hospital chaplain, you don't necessarily, you know, if you're a faith leader out in the community, you don't necessarily understand what is going on in the black box of the hospital. This what I call the end of life conveyor belt. What, you know, the automaticity of how things go, and why is it that so many people, why is it that so many African Americans are dying very highly technologized deaths at the end of machines? It's not what people say they want. So why is it that African Americans are so much more likely than white people to die on ventilators? So the idea being that if you can sort of show these realities and you see them in extremis, very upfront and personal, the people dying on machines, talks about miracle and faith, distrust of the healthcare system, all the things that are issues in the African American community that are really important for us all to talk about, face, and try to figure out how to do better for all of us from the healthcare perspective and the community perspective. So we have this discussion guide that really kind of brings the voice of the healthcare provider, sort of my perspective on them, and then the faith leader, and kind of brings this connected, reflective exercises around these themes that you see in the movie, and creates this experience that I think is very empowering and helpful for faith leaders so that they can then lead their congregants in being more sort of educated about what they need and what they want and how to get it. And so I think that's a really important intervention.
Yeah, because far too long, Jessica, as faith leaders, we've only looked at health from the aspect of, getting healed by God for something that we've gone through. And I'm all for healing, healing services, making sure, praying about, individuals being healed. But there also has to be a very knowledgeable perspective of what healthcare is and what healthcare is about, and how you can benefit from what healthcare has to provide. And when you don't know those things, you can't become a better steward even of your own health without knowing those things. So I think that what you and Cynthia are doing out in the Bay Area is absolutely phenomenal, because you're educating pastors on the need to understand how healthcare is essentially a part of the faith walk of every individual who is a person of faith. And if we don't have, there's a scripture that says, "Beloved, I wish upon all things that you would be in health and prosper, even as your soul prospers." So the scriptures bear it out that our health is essential and monumental, but we have to know the ins and out of healthcare and how things work. And there are too many people who are not dying what we call a good death. And that means that they're dying on ventilators, that they're dying without really having the comfort or the care that they could actually have if they knew more about the things that healthcare has to offer, and things that they can ask for, and not just ask, but I say demand. There's certain things that have to be demanded in order for them to take place.
And just to kind of go back to that, so much of what happens in hospitals around this country is that there is this lack of trust about the system that has not treated African Americans well. Then they come into the system with an active illness and fear, and the fear that anyone has with active illness, and they're confronted with this team that has its implicit bias, or there's disconnection, there's not enough time, etc. And all that explodes and builds even more. And so in those acute situations, people are even less likely to really be able to make decisions that really work for them. And the feeling in our healthcare system is more is always better. And that is what we all think. You watch CNN and look at all the commercials that come on between the episodes, right? It's all about doing more intervention. MD Anderson, we're going to save you. We're going to give you the next best chemotherapy. So there's this vision in America that there's just always something else to do. And so the problem is that when you're feeling distrust and you're feeling frightened and you come in and you say, well, just do more, because what else is there to say? And you don't have a person sitting across from you in an empathic and compassionate way. The thing you're going to ask for is more. And so if we can sort of go upstream and create a sense of trust with the healthcare community, and a sense of sort of educating about what this end of life picture looks like so that people are prepared, and we empower these most important people, the faith leaders of those communities, to be there and for us to incorporate them into the conversation when people are sick in the hospital. We just ignore faith leaders on the outside. These are people who have valuable roles to play in helping to do patient-centered care. So if we could sort of really kind of prepare not only the African American communities, congregations, and faith leaders to manage their part of it better, but prepare the healthcare teams to also come at it from their perspective with a more sort of less biased, more impassioned, more compassionate approach, then we may actually really get to doing what people actually want and figuring out what that is, because it may be different for everybody, but we're not even asking. We're just doing this end of life conveyor belt, maximum full throttle, get them on a ventilator, and then they die on machines. This is happening all the time.
And then really the two most important people in the patient's life, at a time of crisis, healthcare crisis, is their doctor and their faith leader. And the problem is that, Jessica, as you know, the two really never get together. The two never really sit down to discuss, the patient's care plan. And then oftentimes there's not an advanced care plan in place, especially in communities of color. And so when we don't have those advanced care plans and we don't discuss those things and talk about those things, then you leave the two most important people in that patient's life in a situation where they're going to lean towards what they feel is best and what they're most comfortable with. And so that oftentimes they end up canceling each other out, because you have the doctor who says, well, I know things medically. I'm not going to worry about the person's soul or what they feel or about their hope. I'm going to ignore that. And then you have, the faith leader who says, we're not going to listen to what the doctor said. We're going to believe that God is going to do this and God is going to heal. And both can work together in a way that can benefit the patient. And we're just missing that day after day after day, because we don't pull those two key individuals together to discuss these matters.
Well said.
I want to just take the conversation a little bit personal for a moment before coming back to some of the issues that you've raised up. And Pastor Corey, you've shared with us a little bit about how this issue connects for you spiritually, and how health is part of the faith walk, as you put it. That was so beautiful. And Jessica, I'm wondering for you, is there a spiritual component to this aspect of your work? Do you relate to this spiritually in any way?
Oh, absolutely. And, spiritually, that covers so many things. It covers my history as a Jewish person. It's sort of the fact that we are, so much of what we do is understanding the stranger, because we have been the stranger so many times, and sort of understanding that sense of being judged by other people for who we are, and being treated as by others with their implicit bias. And I feel that we are a community, just from a historical perspective, and that is very primed to understand this problem that the African American community has faced, and really be advocates and allies around that. So I think just the history, just my history as a Jewish person, and and feeling that in my bones, and knowing that experience is a big part of this. And then, from a spiritual perspective, I really believe, that we're here to do tikkun olam. We are here to try to make the world a better place. And for me, what makes the world a better place is relationships. And it's really about this incredible beauty of getting to know people who you may not have gotten to know, because we're all siloed in our little worlds. And what a lucky privilege I feel I've had doing the work that I have with patients who are completely different from me, and colleagues who, I would never have necessarily, if I were in the old mode of this hierarchical world, I wouldn't have necessarily listened to a nurse or a chaplain and really saw them as my teacher. But I feel, as Betty would say, blessed that I've opened myself to this world of humility and collaboration, and that I found the palliative care movement, and that I found Betty Clark, and I found Corey, and I found the nurse Pat Murphy, who told me that I needed to shape up and stop acting like an ICU doctor. And all of these things I feel have gotten me to a place that makes me feel less moral distress and more spiritually whole. And so I just feel great optimism for this work. And really, I will say one more thing that we were talking about, Corey, and Shuli and I were talking about before this. I really believe that African American and Jewish communities must come together. We've had our issues over the years, over the decades, but we are meant to be allies. And we have such a shared experience. And Corey and I call each other all the time to support each other, commiserate when things happen to our communities. And I feel that we are natural allies. And I do feel that as Jewish people, we have an obligation, and we will benefit tremendously ourselves from standing with the African American community. And I think that's really important for all of us.
Rabbi Shuli, if I can just kind of dovetail on what she just said.
Yeah, please.
There's something that when we talk about trust in the healthcare system and how spiritually all that can play into that trust factor, for me to look at things from a spiritual perspective, I think that's the thread that is the key to really building a stronger trust system. And the reason why I say that is that, when a doctor, I think when we talk, we give too much, I guess, shine or publicity to race, and not enough about those things that could really commonly connect us. When we take the time as human beings to find out what matters most to the other person, that's when we begin to build a model of trust, because trust is not going to be based upon race. And I think that's an uphill battle, in this country, where when we solely look at, a person and we say, I want to be able to trust them. They're white, I'm black, they're Christian, I'm Jew, whatever the case may be. But I think that when we start to show the other person that what matters most to you is important to me, then trust is going to be built. And I'll give you this story. There was a doctor who told me that she was not really spiritual at all. And she felt like the things that I was saying, things that I've been writing, things that I talk about, that it forces non-spiritual doctors to spiritually try to relate to their patients. And I said, you know what? Here's the key that I want you to understand, is that when you are trying to connect with your patient and you want to build trust, and you find out that that person is a person of faith, going back to what Jessica said, what brought us together, those 15,600 hours of faith, that time that they've spent learning and growing in their faith, when you show respect and honor to that person's faith, and you go into that room and you say, look, I'm here to care for you medically, but I also want to care for you as a whole person, as a human being. And if you don't mind, let me call Chaplain Betty, or let me call, if it's okay, let me call the chaplain and have them to care for you spiritually while I care for you medically. But I want you to know that that part of you is very important to me as it relates to your care. And even if I can't personally provide it, I'm going to make sure that it happens. Now, when you tell a patient that as a doctor, there's nothing else that really needs to be said that will gain trust. That right there is the key to gaining trust. And that is saying to me, as a person of faith, I care about you, and I know that your faith is important to you. Even if I can't, I will find somebody who can. And that to me says a whole lot about a doctor's heart and about really their approach to care. And if they never acknowledge my faith, I'm not going to trust them. I don't care if they're black, white, blue, green, yellow, purple. I'm not going to trust them because they are not acknowledging what's important to me. But once you hit that hot button and once you acknowledge what's important to me, then you got me. We can go from there and and build a great relationship as patient and as a doctor.
Yeah. And if I could say, that for me, it didn't come naturally to start praying with African American families, because I'm like, oh, well, we Jews, we're kind of like silent prayers, or we don't like pray in the same style. And I always felt like it was kind of offensive for me to come in and be like, hey, let me pray with you. And Betty, thank you, would say, just finally start saying, okay, you're staying with us while we pray. And so the first few times I was uncomfortable. I didn't really know what to do. And I cannot tell you what it is like to pray with people who want their doctor to pray with them, and to just be there and to hold their hand, and to Betty luckily usually leads the prayer because I don't know the words. In fact, Betty calls me onto her prayer line quite a lot in the morning. She'll call me and say, hey, you want to join the prayer line with her family and friends? And I'm just blown away by the incredible beauty of the way that people are praying on that prayer line. It's not something I would know how to do, but there is something about connecting and being part of that family that is so powerful, and that makes not only the patient feel better, but it sure makes the physician feel just such profound connection. And it's something I think we should be teaching our medical students and residents how to be comfortable with much more than we do.
And just being present. It doesn't even take you knowing the words, so to speak, or even leading the prayer, but just being present during the prayer. You don't know how many doctors that I've witnessed leave the room when the chaplain comes in, or the chaplain gets ready to pray, and they're just like, okay, I'm going to go to my next patient.
That was me. I think I was the person you're talking about.
Well, when I was in rabbinical school, doing a unit, 400 hours of CPE, of clinical pastoral education, was not yet required. But I think right when I finished, the Jewish Theological Seminary started requiring that for all rabbinical students. And it sounds like there may be a sort of comparable parallel educational module that should be in medical schools. And I think it's so beautiful to hear what you're talking about in terms of relationships and getting close. We were very, very blessed at BJ to have Brian Stevenson address our congregation almost 2 years ago, a year and a half ago. And if you're not familiar with it, his sort of framework for social change, this 4-part framework begins with the idea of proximity, of getting close to someone. I mean, he talks about it in the context of the criminal justice system and mass incarceration.
Oh, right.
The idea of proximity, of needing to get close to someone to understand who they are, what their story is, what are they coming to whatever experience you're in with them. And that's very much what you're stressing and suggesting is necessary for medical students, for doctors, and changing the structure of the medical teams so that more of that story can be seen and honored and recognized, which is so incredibly powerful. And I do want to kind of press a little bit, because I think the interventions that you've named, which seem, will have, to the extent that they're already in effect, are having tremendous impact, and to the extent that they will grow to other places in the country, that God willing, they will have success and have impact there. You're talking about interventions within the medical community and interventions within the African American communities and those faith leaders. And I know this isn't your area of expertise, but I just want to acknowledge the real systemic issues that you brought up at the beginning, Corey, in terms of housing and education and access. And, those are not going to be addressed by some of the things that you have lifted up as things that you're doing inside hospitals, inside medical schools, inside specific churches or Black communities. And so when you talk about, Jessica, the opportunity for the Jewish community to be, to be in relationship with African American communities, to be an ally, what could that possibly look like in terms of addressing some of the more structural issues? Not all of us are doctors. Not all of us are chaplains. Our work is not going to be in those spaces that you've described, but to the extent that you feel comfortable, is there something that you could speak to that our community could do that would help address some of these larger structural issues? We'd love to hear from your perspective on that.
Yeah. So I would say number 1, 2, and 3 is create relationships. Just create relationships. It's really, at first, it may be, I know that when I was in medical school, there's a small number, but there were African-American students, and they hung out together. And I was friends with a couple of them, but there was this siloing. And I really think we have to figure out, both in medical schools, on hospital teams, and out in society, particularly starting with places like faith communities, because I think this is an opportunity to really become friends. It's pretty simple. Invest in relationship. It's not necessarily easy, because when we're from different cultures, and there's all, as we talked about, all this distrust and all this stuff in the way, when you go out on the street in Manhattan, and there's stuff that's just there that separates us all with all of this infrastructural racism. It's part of how we live within that structure. So if we force ourselves to say no, we're going to come together and be friends. We're going to try. And in the beginning, it may be a little stilted. Okay. People have different cultures, but as people get to know each other, if there's a regularity of meeting, a regularity of purpose, and a mutual desire to forge a true relationship, people can figure out how to get past those cultural constructs where we stay with our people, and really forge a relationship. And there's always going to be differences. The truth is, here's the honest truth. Corey, let me ask you, is it more comfortable if you're really kicking back on a Sunday afternoon at 5:00 and you want to have a beer? Now, you and I have become friends, so I won't be offended, but would it be more comfortable for you to just kick back and have a beer with someone who's from your culture, who you don't have to explain yourself to? They understand the issues that you're thinking about. They understand your experience. It's not someone like me who you have already a relationship with. We talk all the time. Somebody a white person versus someone who's from your community. Who would you choose to spend time with?
And
I'm
be
honest.
I'm gonna be honest with you. It depends on who I fostered that relationship with, because there's some people who look like me that I don't have that relationship with, and some people look like you who have a stronger relationship with. So I think it all comes down once again to human interaction. But you make a strong point, and maybe I'm an anomaly when it comes to this, but your point is that whoever you build community with are those individuals who you're going to feel more comfortable with in sharing not only business information, but personal information about who you are and your kids and your family and what's going on in your life, and those who can relate. Because you can have people of different cultures who live in the same community who have the same issues and struggles and problems. And so those individuals are going to be closer than somebody who may look like them but not live under the same circumstances.
But I would say that even someone who lives under different circumstances, there are ways to, forge a relationship. I think we have to make a practice. It's almost like of just forcing ourselves out of our comfort zone and really engaging. And we'll start with faith communities, because look at all the people on this call. There is a way to do this, and it takes work. It takes stepping out of your comfort zone. I know I step out of my comfort zone all the time, and it has been a profoundly life-opening experience for me. And I just think that there are many people who want to do that who just don't know how. And I think if we can figure out ways to connect communities and really start to have regular social gatherings where there's mixers and people get to know each other and talk together, and people don't stay siloed on one side of the room or the other side of the room, really trying to break down the things that human beings tend to do, the tribal things that human beings tend to do, because we Jews are pretty tribal. And we have to try and just try and break through that. And I think it can work, but it takes some discipline and it takes structure.
And
I
Rabbi
also,
Shuli,
I just, oh, go
oh,
ahead,
go ahead.
Corey, please.
Okay, no, I just want to say that it has to be intentional. And I think far too often we sit back and we say, we feel pity upon the community that may be struggling. We may drive past certain communities and we say, wow, it's too bad that they live like that, or it's too bad that they don't have this or have that. Instead of saying intentionally, how can I get involved? Maybe with one person's life to make a difference. Maybe I can be an advocate for one person and change their life so that others can have their lives changed subsequently. But it comes down to where your heart is. How much of a burden is this for you to see other people live better? And if that is not a burden on your heart, then nothing's going to change. But my heart aches when I see people suffer. My heart aches when I see people in pain. And so I have to do something about it. I was just in the park the other day in my community running, and what did I do? We saw bottles and cans, we picked them up, put them in the trash, clean up the community, help people to see and to understand that you got to take care of where you live. And if you lead by example, instead of just saying, look at what they've done or look at what they're not doing, when you lead by example and you intentionally get involved, that makes the difference. And I think, Jessica, you and I, we talk about this all the time. It's important to make sure that you have people who can stand with you, in such a time, as this. And I think also, as a community, we got to get politically involved. We got to elect the right people who care about these issues, who care about and have concerns about other human beings. And so I don't want to get on a political soapbox, but politics play a major role in all of this that we're talking about, in how people are insured, in how people have access to health care, and who gets health care, and what does that look like. All of these things are politically inclined. And we have to make sure that we are holding our elected officials accountable for the way communities look, food access, healthcare access. All of these things have to be intentionally addressed and addressed loudly.
Wonderful. Thank you. I want to make one comment, which is a little bit of an aside, but I think very important to mention, which is when we talk about the Jewish community and the African American community, in some ways that erases Jews of color, and not all Jews are white, and there are Jews who are members of the African American community or are people of color, and I don't know that there may be another conversation to have about what is the experience of Jews of color who live in both worlds, both communities, maybe walk into hospitals or a doctor's office and are assumed to be a certain identity, and then also have another aspect of their identity that comes out in the conversations. And so I want to just make sure that we don't omit that from our thinking about this. That's part of actually one of the goals of our Race and Us initiative is to learn more about Jews of color in America and in American Jewish life. We're not talking about that specifically today, but I think it's important to hold in mind that when we talk about what are the alliances or the relationships that we build, we have people of color within our own community. And that may be an important place to start, just within, speaking from the BJ perspective, Jews of color within BJ. And do we have relationships there? Do we know what their experience is like? I'm speaking now as a white Jew. Do I know all the Jews of color in our community and their experiences in healthcare situations or other situations. And just that proximity may be an important place to start. And we're all part of, those of us who are on this call who are members of BJ, we're part of BJ. That's, it's not, you don't have to go too far from what you consider
Right.
to be your community to even begin to think about how do I foster those relationships. So I just want to remind us of that as well. And I think, Corey, everything that you just said regarding political engagement is obviously so important. And now more than ever, it feels like, and people may know that at BJ, we have a relationship with a local New York-based organization, the Alliance of Families for Justice. Doesn't work on healthcare issues, but works on issues of criminal justice reform and mass incarceration, and have a number of advocacy campaigns that we've been involved in. And so I encourage people to, you can email me or look on our website to get involved in that work. It's a local New York-based organization that's doing some of that political work to address some of the larger structural issues that are sort of rooted in racism in this country, particularly with regard to the prison system. So there's a little bit of an aside, but I don't want to forget to mention that. It's an important piece of work that people can get into. I want to thank you so much for your time and for bearing with the technical difficulties.
Yes, thank
and
you.
and persevering and offering us your wisdom, and I want to invite Rabbi Felicia Soul to close out the evening in this program with her words of faith and wisdom. Felicia.
Not now. Hi, everyone. Thank you, Dr. Zitter and Pastor Kennard. We're so grateful for the time you've spent with us this afternoon. And in many ways, I feel while the healthcare system is obviously particularly unique, much of what you shared today is not specific only to the healthcare issues of, the way assumptions and implicit bias play out with police, or the same tropes keep coming through in the discovery that we've been in as a community, in the stories that we've been hearing from our members at BJ who are of color, to the larger world. And so there's something I think that we continue to learn about the systemic and institutional issues that pervade the entire nation of America, whether it's the healthcare system, the justice system, and on, education system. So I don't know that that should be disquieting rather than comforting, but I think it's also important to continue to see that to be true. So I just want to stick with what you said, Pastor Kennard, about the burden on the heart. I think we as a community have been carrying that burden on the heart. And part of, I think, why we are in these conversations and seeking to learn is because as a faith community, as a Jewish community that's diverse racially, economically, in so many ways, it's our spirituality that is the burden on the heart that forces us to ask questions. And so I want to honor what you said, Dr. Zitter, about cultural humility. And one of the things that we've been learning in all this work on race and us and our implicit bias is asking the questions of what we don't know, rather than putting out data or facts that we think we know to make assumptions about who someone is or who someone's community is. And to come, that curiosity and humility are a deep part of what faith is about in trying to approach another, whether that person looks like us or doesn't, or whether we're assuming that they're like us or not. And I also want to honor what you said about getting to the story. When we look at all the people on this call, there's each and every person has a singular story that's not duplicated, because we're all uniquely created in God's image. And that's one of the gifts our tradition tells us, is that no person is the same and no person's experience is the same. And so rather than hoisting a generalization about one person's experience on another, it's incumbent upon us as a burden of the heart to really seek out the individual and unique story of who's in front of us, knowing that issues of racism and classism play out in profound ways in our society, but that shouldn't distance us from seeking to know the unique story of a person. And finally, I just want to raise up for us how, you know, a hospital, a doctor's office, those are holy spaces. And as a rabbi or as a nurse or as a doctor, a pastor, or a family member or a sick person who's in those rooms, it's upon us to recognize that life is so precious that we can't institutionalize and disavow what we're trying to actually accomplish in those very precious spaces, which are filled with pain and hurt and obviously a person's story. And so thank you for lifting up and for being part of the work that's trying to honor the truth of that, which is the spiritual conversations, the value of what it means to live truly and to die with love and care and honor is a holy question. That is where the intersection of faith and medicine don't collide, but really are part of the same conversation. And palliative care, Reimagine, all this work that's being done to kind of bridge that divide and to say, really, what we're trying to create is the honor of life and the process towards death that is a holy I mean, really holy process, even as it is a painful process. So all the more so in these times when people can't get into those rooms with one another because of the nature of what we're living with. So I want to also just invite that back to our community. This isn't only an issue of communities of color with 16,000 hours of faith hours in the church. This is true of all of us who are averse to giving up what we consider hope and to our desires to control our ends, that this conversation is an invitation upon all of us to ask the questions of what is hope for us, what are end of life issues that we need to deal with in advance and be educated for, so that we don't end up being on ventilators without people we love nearby or without the ability to make decisions. This is a national issue about what it means to live and die with honor that intersects with racism and questions in our country. So I don't want this to be an issue that we're putting on another community. It's our collective issue. And I want to really thank Dr. Zitter and Pastor Kennard and Rabbi Shuli Passow for being in the conversation. Also, Jeannie Blaustein, our beloved member, former president, as well as a founding board member, founding chair of Reimagine, for elevating all these questions for us to be able to be in this holy conversation for forevermore, really. So thank you.
Thank you.
Thank you, everybody. Thank you, Felicia. Thank you for joining us. We look forward to seeing you and continuing this conversation. And thank you, Jessica and Corey.
Okay.
All right.
Bye-bye.
Bless
Bye.
everyone.
Bye-bye.